Welcome to This Explainer. Today, we're diving into a real medical detective story, the lingering mystery of breast cancer recurrence and the incredibly cutting-edge tools we're now using to defeat it. We're going to move way past the standard protocols to look at the stealthy biology of rogue cancer cells and explore the highly precise ways modern oncology is hunting them down. Okay, let's jump right in with a fact that is quite honestly staggering. For hormone receptor-positive breast cancer, the risk of distant recurrence doesn't just magically disappear at the 5-year mark. Based on massive data sets from the early breast cancer trialists collaborative group, it actually remains a steady threat for up to 2 decades. Think about that. You could be completely disease-free for 15 years only to suddenly face a relapse. So to solve this mystery, here's our agenda for today. We'll cover 1. The anatomy of a recurrence, 2. The biology of dormancy, 3. Genomic profiling and prediction, 4. The breast cancer index, 5. Targeted medical interventions, and 6. Surveillance and lifestyle factors. We're going to cover the whole shebang, from rogue cellular biology to the lifestyle defenses that patients can actively use. Section 1. Anatomy of a recurrence. We really need to accurately classify this threat because not all recurrences behave the same way. The crucial thing here is distinguishing between local, regional, and distant relapses. A local recurrence, say after a lumpectomy, is often highly treatable, but medical oncologists know that local regional recurrences, meaning the cancer came back in that same general area, are rarely just local hiccups. They essentially act as a biological warning siren for an eventual or even concurrent distant spread to organs like the bone or lungs. Which brings us to a really profound biological question. If standard adjuvant therapies, like cytotoxic chemotherapy, are designed to wipe out rapidly dividing cells right at the initial diagnosis, how on earth do these rogue cancer cells manage to survive and just re-emerge 15 or 20 years later? Section 2. The biology of dormancy. The answer lies in a stealthy, fascinating phenomenon called cellular dormancy. These disseminated tumor cells basically act like sleeper agents. During early carcinogenesis, some cells escape into the bloodstream and go hide in specialized niches, like your bone marrow. Then they enter a state of complete cell cycle arrest called quiescence. They just hit the pause button and wait, sometimes for decades, until something like aging, tissue damage, or inflammation triggers a sudden reawakening. So how do they stay hidden for so long? Well, they actively suppress their own metabolic pathways. Specifically, they shut down the mTOR pathway, which is basically their growth engine, and they alter their cellular adhesion, essentially changing their cellular glue. By powering down these engines, these cells become virtually invisible to standard chemotherapies, which are really only looking to destroy active, replicating cells. And the clinical data proves that no one is entirely immune to this dormancy threat. Even patients with small, node-negative tumors carry a 13% absolute risk of distant recurrence over 20 years. And that risk aggressively scales up with tumor size and nodal involvement, peaking at over 40% for higher-stage disease. Section 3. Genomic profiling and prediction. To fight this without toxically over-treating everybody, oncology relies heavily on precision genomic profiling. The one-size-fits-all approach is out. Assays like Oncotype DX and MammaPrint actually decode the tumor's exact genetic signature to build our defense. These tools, which are backed by massive trials like TAILORx and MINDACT, definitively tell us who actually needs chemotherapy and who can safely skip it. This spares thousands of patients from completely unnecessary toxicity. It's incredible, really. Genomic profiling can now identify patients whose biology is so favorable that we can scale back their treatment. If a patient falls into the MammaPrint ultra-low risk category, they have a near-perfect 99.6% breast cancer-specific survival rate at nearly 9 years. For these folks, clinicians can safely consider de-escalating those harsh endocrine therapies. Section 4. The breast cancer index. But what about the patients who aren't low risk? Do we extend their endocrine therapy to 10 years to hunt down those sleeper cells? That brings us to the breast cancer index, or BCI. It acts as a clear, binary yes or no genomic test, usually done around year 4 or 5 of treatment. It looks at estrogen-mediated signaling to tell us exactly who will benefit from an extra 5 years of pills, that's the high group, and who derives absolutely no benefit from extended therapy, the low group. It's a game changer for preventing overtreatment. Giving patients and doctors this specific genomic prediction is totally revolutionary. In the BCI registry study, seeing these results actually altered physician treatment recommendations in over 40% of cases. Plus, it massively boosts patient compliance when they know for a fact that their specific tumor biology demands the extended treatment.
Section 5. Targeted medical interventions. Beyond genomic testing, a totally new arsenal of targeted medical interventions has revolutionized survivorship.
By specifically targeting the molecular engines of the cell, we can actively suppress recurrence. Drugs like abiciclib and ribociclib act as brakes to halt cell cycle transitions. Meanwhile, PARP inhibitors like olaparib disrupt DNA repair mechanisms specifically in BRCA-mutated cancers. These are costly drugs, sure, but they are highly effective at traumatically fortifying the body against a relapse.
We also know that the bone marrow is a favorite hiding spot for dormant cells. While adjuvant bisphosphonates literally alter your bone physiology, making that bone environment completely unlivable for cancer cells. Keep in mind, though, meta-analyses show this incredible recurrence reduction is strictly limited to post-menopausal women.
And if a distant recurrence does happen, the therapeutic landscape has totally shifted. The rapid evolution of antibody-drug conjugates, like TDXD, has completely shattered the old binary definition of HER2 positive or negative. We can now effectively target tumors classified as HER2 low and even HER2 ultra-low, which offers incredible new hope.
Section 6. Surveillance and lifestyle factors. Finally, how does a survivor actually take back control once primary medical treatments are done? Here is a really crucial and actually highly reassuring point. Constantly scanning the body for a recurrence doesn't save lives. Rigorous clinical trials show that intensive, routine imaging, like CTs or bone scans, for asymptomatic patients only massively increases anxiety and leads to false positive biopsies. Standard, symptom-directed care is still the gold standard.
Instead of demanding endless scans, survivors can take charge with evidence-based lifestyle changes. Weight management is huge because postmenopause, adipose tissue actually synthesizes the very estrogen that fuels those dormant tumor cells. Limiting alcohol, eating high-fiber diets, and managing weight actively suppresses the microenvironment that cancer relies on to wake up.
But the absolute most powerful lifestyle tool is movement. Just meeting the standard exercise guidelines of 150 to 300 minutes of moderate activity a week post-diagnosis correlates with a massive 50% reduction in the risk of recurrence. It's not just staying healthy, it's a biological intervention in its own right.
By combining genomic profiling to understand the exact threat, targeted therapies to lock down the cellular engines, and lifestyle modifications to alter the host environment, we are no longer just sitting around waiting in fear of a recurrence. We are actively disarming it. Which leaves us with a pretty thrilling question to end on. With all these precision tools at our disposal, how close are we to outsmarting tumor dormancy once and for all?